So what this is a webinar. The webinar has been sponsored by Novartis. We much appreciate the webinar has two sections. The radiological new innovations about multiple sclerosis and the new diagnostic criteria, and then there is another section on how to monitor the disease that needs will chair. And we very much appreciate, of course, the sponsor did not have any influence on what we're going to discuss, so they're not to be blamed. Novartis is not to be blamed. So let me introduce the first part of the webinar. I'm Nikos Evangelou. I'm the professor of neurology here in Nottingham, and with the rest of the team here in Nottingham, we have been investigating central veins and paramagnetic rim lesions for a long time, and of course, we have been delighted that they are now part of the diagnostic criteria. I was asked to organize the session because we have all appreciated that the central vein signs and the new MRI biomarkers for multiple sclerosis are not used as widely as would have liked to be used in the UK and abroad. And I invited Pascal. Pascal is the person in the world who knows more about how to get the best images so you can see these new biomarkers. Is the Pascal contributed to society with one of the best sequences that we have in detecting central veins and paramagnetic rims, and he will tell us, how to get the best possible images. So thank you, Pascal, all the way from Los Angeles. So what time is it, Pascal, there?
It is 8:05, 8:04 a.m. and I'm
8:04, 8:04.
second
Probably,
cup of coffee.
Pascal with his American way of working, you can see from his American accent, probably he was wake up at then at 5 o'clock working. And then we have Rob Denin, possibly the radiologist, at least here in the UK, with the most experience in interpreting the central veins and paramagnetic rims. Rob is a professor of neuroradiology. He has participated in many of our studies in studying the central vein, and more importantly, I think over the last few years he has been clinically reporting central veins and paramagnetic rim lesions in Nottingham. So he will tell us his perspective. Pascal and Rob, thanks a lot for joining us. So with this, and because there is always a bit of a pressure on time, so what's the objective? The objective is just to summarize. I'm not going to tell you all about the diagnostic criteria, the new McDonald criteria, but I will focus a bit on the neuroradiology point of view. Then we will hear about central vein signs and how do we identify, how do we get the best images to identify the lesions with the central vein, how do we get the best images and how do we identify paramagnetic rims and what does it mean? And importantly, how do we get them in a hospital near you? I think the priority at the end of the webinar would like people to come along and say that, okay, are we using it as we ought to be using it in our hospital? Are we reducing the number of lumbar punctures that we do? So this is the objective of the webinar, and I think I might need to, and then, of course, Nitz, do you want to say something?
Yes, thanks, Nikos. So I will be the warm-up act, but it's the wrong way round. So I'll just ease everybody out with my own personal opinion, followed by some data from some other large trial-based publications to round things out.
So this is the second part of the webinar. And how do we unmask the and more importantly, we would like quality counts. It is quality counts, of course, says Joanna in the questions and the live questions. So what I would like to do, I would like to put as many questions as you can in the question and answer section. We'll try to answer as many of those as possible. Even if we do not manage to answer it, if you put your name and possibly where you work, we might be able to come back. I think, especially for the first part of the webinar, the idea is that if you have a problem and you cannot implement the central vein sign, we will figure it out in your scanner how to do it, and that's the plan. So with this in mind, with a bit of luck now, I will share my first slide. What do you think of that? So as I said, obviously it is dark now. It is miserable, and it was raining a little bit in the morning, but this was on a good day from the University of Nottingham. And as I said, I'm Nikos Evangelou. My brief introduction will go as follows. So why have we updated the diagnostic criteria? We could have stayed with a description of Charcot, saying that, oh, this is multiple sclerosis. We could have stayed with the diagnostic criteria of Poser or even earlier. But there is a steady improvement, and we have seen a steady progression of our knowledge, advances of our knowledge, especially about the biomarkers. And we have laboratory markers like variations of analysis of the oligoclonal bands. And now we have different ways of analyzing the cerebrospinal fluid, but this seminar is mainly focusing on the neuroradiological, the type of advance that we can get closer to the diagnosis of multiple sclerosis without the lumbar puncture. What is important is, and over the last 20 years, we have done lots of studies for this. It has also been recognized that the optic nerve plays an important role. We know that in pathology, almost 100% of people with multiple sclerosis, they will have a lesion of the optic nerve. So if we find any evidence of optic nerve involvement, is an important fifth site for identifying lesions in MS. The aim is to get to an earlier diagnosis. Even we have seen earlier recognition and definite diagnosis of multiple sclerosis with the previous diagnostic criteria, but even earlier diagnosis will not harm. And of course, we need to reduce misdiagnosis. We need to reduce all these people that they have some white matter lesions and we don't know what's the white matter lesions. So we need to be very specific, not only sensitive, but very specific in the diagnosis. And some of the biomarkers, the central vein, typically is very, very useful in distinguish between the people that they have multiple sclerosis and other conditions. The diagnostic criteria are now uniform, and the idea of the uniformity is that we apply the same criteria for people with primary progressive MS, with relapsing, remitting, early stages, later stages. It's a unified, and the idea, of course, is that they will become available and should become available throughout the world. And essentially, we have to strike the right balance between being sensitive but also being specific and to have a clinical impact. And I think my delight with the new criteria is that it has a clinical input. It has really changed the way we diagnose MS here in Nottingham. So the radiological important things that you should pick up from the new diagnostic criteria is that nowadays, if you have somebody present with clinical symptoms, if you have somebody with an optic neuritis, with a neurological event, and examining with an MRI, because MRI is essential, you cannot have multiple sclerosis without an MRI. So the good old days that you have got 2 relapses and nobody has done any scans is not acceptable anymore. So we need to have abnormalities on the MRI. But if you have lesions in 4 out of the 5 locations, then you can diagnose confidently with multiple sclerosis. You don't have to wait until another relapse takes place, or you don't have to wait until another lesion develops. So somebody with an optic neuritis and a juxtacortical lesion and a lesion in the periventricular area, the spinal cord and the optic nerve, that is enough to say this is definite multiple sclerosis, is not clinically isolated syndrome. So this dissemination in time is no longer necessary. The other important thing is that the central vein signs can be diagnostic. If you see, and I'll give you some examples, that this is a diagnostic test, and also paramagnetic rim lesions can be very useful. And if I go to the central vein signs, this has really started 200 years journey of discovery from the first pathological description that in the center of the white matter lesion there is a blood vessel, to Barkov reporting that if you look at two different scans, you can possibly see a tiny little vein where there is a T2 lesion, to the first observation at 7 Tesla with Emma Talatar as the first author saying that, oh, we can see lesions with the central vein using the ultra high field scanner. And then, a number of studies have been done in a number of places here in Nottingham, and the first diagnostic test developed in 70, and eventually last year, we have reported both from the big American study as well as the European study, the UK study, that they can be comparable to the oligoclonal bands. So for the first time also, we can diagnose multiple sclerosis, and I'm copying from the paper. This is nothing very clever. It's very nice graph. So we detect an white matter lesions in individual who complains of migraines. We go to this is incidental findings. The story is, do we have any other cause for these white matter lesions? We don't have any other explanation. Then we look and say that if the lesions are in two sides, periventricular and posterior fossa, then we can diagnose multiple sclerosis if one of the following is possible. We can do a lumbar puncture, or we can look for central veins, and Rob will tell us about the central veins, or we can wait for another lesion to develop to have dissemination in time. So this is the diagnosis of multiple sclerosis purely on MRI and, preferably on something non-invasive like central vein sign. And if instead of an MRI, we have some clinical symptoms, in a very similar way, we say that, is there any other explanations? No, there's no other explanations. Then, do we have lesions present in two CNS sites? And then again, you go down the same pathway. You can say that if it is positive oligoclonal bands, if it is central vein or disseminated, or alternatively, as I said, in 4 or 5 anatomical sites. So this has been transformative, I think, in Nottingham, because usually we get in our clinical practice, we get the MRI report that a general practitioner has requested. And what used to happen is they used to say, oh, let's book an appointment with a neurologist. The neurologist will have a look and then will say that it's an incidental, it's radiological isolated syndrome. Shall we do something? So now we do some triaging. We look at the scans. If I identify 4 locations, immediately I book them to the MS clinic to have a conversation. If I do not, I arrange another scan with the sequences that Pascal will explain. And once I have the central vein or not, I see them in the clinic. And this can lead to a very quick diagnosis or reassurance that we do not have multiple sclerosis very quickly. So we have applied the new criteria, predominantly the central vein sign. We have found here in Nottingham that we are giving the diagnosis faster. The lumbar punctures, essentially, we stopped doing lumbar punctures in Nottingham. I think we have done one over the last year. And of course, because of lack of day case unit, we have saved some money for the poor NHS. So this is an interactive webinar. So I would like as many questions as possible. So the idea is that we need to implement the central veins and the paramagnetic rims in all the hospitals. We have put some of these uh, guidance that Pascal and Rob has put in a website, the centralvein.com, www.centralvein.com. You can go and you can see some examples. If you think that we need to put more examples, let us know and we can add this. And I'm about to ask Pascal to tell me how to use the best sequences to see the veins. Pascal,
Wonderful. So
all
thank you,
yours.
Nikos, again for the invitation, and thank you to UK Academy Program for this webinar. So as Nikos pointed out, I am in LA at Cedars-Sinai Medical Center, and I've been working on the topic of imaging central vein sign and paramagnetic rim lesions for quite some time now. And as Nikos pointed out, we have a lot of technology now available, and not just at 7 Tesla, but also on 1.3, on 1.5 and 3T. And these are the systems that you guys have in the hospitals. So what I really want to do today is show you all the tips that we have in the book to implement that on your scanners and then properly open the images for interpretation, as Rob will show you later in these cases. So let me just go started here. So I do have some disclosures, nothing really relevant to this topic. I just want to emphasize that I am not a neurologist nor a radiologist. I am an MR physicist and solely talk about sequences today. So the good news is we have a few options here if you want to go on your clinical scanners and image this biomarker. The key thing is to use what we call the susceptibility sensitive MRI sequence. Why do we want to do that? It's because the biomarkers that we're looking at that Nikos introduced, the central vein sign or CVS and paramagnetic rim lesions or PRL, are magnetic. And we want to use a sequence that can detect this magnetism. In this case, it's called paramagnetism because deoxygenated blood, which is the venous blood, is highly paramagnetic. And the tissue iron, which is located in this on the edge of these lesions, the chronic active lesion, or what we call PRL, is also paramagnetic. So once we have the sequence to detect these features, we can then assess them and then use them clinically. So as you can see in this table that I put together, you can see there are different options depending on the biomarker, the so-called SWI, T2 star weighted, and flare star. And for the PRL, you can use some of the same or some variant. So the good news is all of this is FDA cleared and could be used on any of your clinical scanners. Now the difference though will be the availability depending on the vendors. And this is something I want to put up front. Not all vendors offers all options as of now. So your choice will be probably guided by what you have at your center. And here's availability across the 3 major vendors, which is most likely be present at your centers as of today. So the good news is for the SWI, or susceptibility imaging, this is a fairly established sequence that is available across vendors with different variant or acronyms, but they're in a sense the same scan. So for Philips user, it's going to be SWIP, for Siemens, it's going to be SWI, and for GE, it's going to be SWAN. The more advanced sequence that I'll touch upon later are not yet fully available across all vendors, but some offer them already, such as Philips and Siemens for the T2 star 3D EPI. And then the latest and newest called Flare Star is solely available on Philips. So the bottom line is if you're a Philips user, you basically have the most choice. If you're a Siemens user, you have a few options. If you're a GE user, you are limited to 1 option. But the good news is you can image both biomarker no matter what. The difference is going to be primarily in sensitivity and the workflow to look at them. So here's, I'm going to start with the most established and most available across sites, which probably would be the easiest for you to implement. It's called susceptibility imaging. So again, different acronyms, different vendors, so make sure you look for the right name. What they typically do is they acquire axial views that I'm showing on the right. And then you can see typically if they're both existing in MS plaque, the ring, which is the iron rim, and the dot or vessel that goes through it, which is a central vein, right? And these are typically 3D acquisition. We recommend thin slices. And then the data has shown that we can actually detect that at all field strength, all the way up from 7 Tesla down to 1.5 T. Now, I want to emphasize a little bit of the workflow because sometimes the lesions are not clearly visible on the susceptibility weighted imaging scan itself. As I'm showing in this yellow box, you actually cannot see the lesion, although you can see the vessels. So what you really need to do is pull your T2 FLAIR scan and then do a precise side-by-side comparison so you can convince yourself that yes, there is a T2 lesion there, and yes, there is a vessel that goes right through it. And that is the definition of CVS, and Professor Dinan will talk more about that later. But what I want to emphasize here is a little first tip for radiologists and MR physicists. You can actually optimize your SWI very simply by just changing one parameter, which is called the flip angle or FA. And as you can see, when I change that flip angle from 15 down to 5 degrees, I can modulate the image contrast, change the CSF appearance, make it bright. And guess what? The lesions as well bright. So now you do have an option for seeing both lesion and vein in one image, which greatly facilitate the workflow, as you can imagine, since you don't need to pull the two scans side by side. But here's the example that I showed previously when you have them side by side. So T2 FLAIR on the left, standard SW in the middle, and then the optimized on the right. As you can see, the lesion is right there and the vein is right through the middle. And so what we found, and this is a paper in publication on the review, soon hopefully, we show that actually that provides superior detection, superior confidence in calling this, and ultimately superior diagnostic sensitivity. One thing I want to point out with the SWI, especially this 3 mm slice thickness, is when you reformat them, especially in coronal views, it becomes very blurry, and that's the lower resolution. And as you can see, for axial views, it's okay, but if you want to look at the vein in different rotation, it's going to be very limited because of this blurred view. So that's why I want to pivot to this newer generation of sequences, specifically one that I have developed a few years ago and published on, which we call the T2 star weighted 3D EPI. And this is a different T2 star from the conventional GRE or gradient echo. I want to point out this is very high resolution, so we call that sub-millimeter isotropic voxel, meaning the resolution is preserved in all plane of view, as I'm showing here. So whether you look in sagittal or coronal, the details are there, and when you zoom in, you can clearly see the vein regardless of the orientation. And that really greatly enhanced the sensitivity for detection of central vein sign, because now you're independent of the orientation of the vessel that you're assessing in the brain. And again, this is feasible at all field strength, and it's clinically available on 2 vendors as of now. Here's just an example of one case that I scanned back in the days when I was at the NIH with Dr. Reich. And what we did is we put the same subject in different scanners, ran the same sequence, that T2 star API. And as you can see, the central vein sign is detected on all field strength. Of course, the lower field you go, the little blurrier the picture gets, and the contrast is lower, but it's still feasible at 1.5T. And here's another trick that I wanted to show, which is basically a combination of existing sequences. So if you run your T2 FLAIR and your T2 star, you can combine them to create a FLAIR star. So why we do that? Well, a trained radiologist might not see the need for this because they can still pick it up on the T2 star. But a neurologist or somebody who's used to look at T2 FLAIR would actually maybe appreciate this because it looked like a T2 FLAIR. As you can see, the only bright signal are the T2 lesions. But the difference to a T2 FLAIR is now you can see the veins and pick quite easily now the central vein sign when it's present on these lesions. So this is a post-processing trick. It still requires a 2 scan to be acquired, but allows you to visualize the central vein sign in a more familiar manner as you will do with a T2 FLAIR. And here's a side-by-side example. These are scans that I did at Cedars-Sinai on one of our MS patients, just to show the difference in image quality and assessment when you run the 3 sequences on the same subject. So top row, you can see the standard SWI. Again, the issue of not seeing the lesion, but you have nice veins. And the second issue is when you reformat, and here's in a coronal view, you have the blurriness. This can be addressed with a T2 star high-resolution 3D EPI, where now both the vein and the lesions are visible in either axial or coronal because the resolution is preserved. And then if you want to run this additional FLAIR star cross-processing like I did here on the scanner, then you can get a FLAIR-like image, but enriched with the vessel information, and really helps you pick up again the central vein sign. So how about pearls? We talked about these iron rims before. The good news is the sequences the same sequence I showed you before can also pick up the pearls. So here's an example, T2 FLAIR. So you're looking for a T2 hyperintense lesion signal. You want to make sure this is a non-enhancing lesion because by definition pearls are chronic. So if you have a post-GAD T1 or you have a preceding T2 FLAIR scan done 6 months before, you want to make sure that T2 lesion pre-existed. It's not a new acute lesion. And then you go to your SWI, for example, and then you make sure that you see this iron rim, which corresponds to this paramagnetic signal that I described before. Now, I want to show another trick in the book. The scanner provides images for free. And if you look in your PAC system or whatever system you look for the images, you should see another image from the SWI called filter phase. And so different vendors will have different convention. We recommend that you're looking for what we call the right-handed convention, meaning both the vessels and the cortex and the rim should be hypo-intense. So it's consistent with your SW image. You're looking all the time for something that is hypo. And as you can see nicely these rims on these filter phase images. And it's actually pretty important sometimes because there is a pitfall on some of the SWI images where the lesion can appear hypo-intense. I did mention before they can be ISO, meaning invisible, but they also can appear hypo-intense. And when you have this, of course, it makes it difficult to detect a hypo rim surrounding a hypo lesion. So that's why, for example, the filter phase image can be extremely useful to make sure you do see this clearly the rim where the core of the lesion is more hyper or ISO, right? And then we actually have a manuscript under review that's showing this is actually quite frequent issues on some vendors. So I really strongly recommend that in your practice, you make sure that you have the reflex to open that phase image when available to you. And can you do that with the EPI? The answer is yes. You have to make sure that you have the MR tech or the physicist collect the phase image on your scanner for that sequence. And you will see the rim, for example, in this case, on both T2 star and phase. And the beauty again of the 3D EPI is you can reformat and still see that rim regardless of the orientation of the image you look at, and convince yourself that actually it's more than a rim, it's a sphere, and this is indeed what you're looking for. So I'm going to wrap it up here on just a practical recommendation for the clinical implementation on your site. We have recently published, along with the McDonald paper, an article in Lancet Neurology. This is the current international guidelines from three consortium, the MAGNIMS, the European Consortium for MS Imaging, the CMSE, Canadian American, and then North American Imaging and MS Guidelines. I strongly recommend you have a look at this paper, specifically in the appendix section, where I planted practical step-by-step guidance for implementation of what I just said above. But the bottom line is, we strongly recommend that you use a 3T system. If you have access to the SWI and optimize SWI, just do it if that's easy for you. Make sure you can optimize it using low flip angle and collect the filter phase images. If the vendor allows you to collect this more advanced scan, then we recommend to swap it and use those instead because of the higher sensitivity. And typically T2 star, 3D EPI, and the Flutter star will be the ones to go for. And again, collect the filter phase images so you can also detect the pearl along with the CVS. And then for those who are limited to the lower field strength, this is still feasible. That's the good news. However, you ask your MR physicist to push a little bit the echo time to increase the sensitivity. Or if you have GAT on board because you want to detect T1 enhancing lesion, you can actually sync the acquisition of that scan with the GAT injection to maximize the sensitivity to the volume, to the blood effect before you collect your T1 post-GAT. And I'm going to wrap it here. And here's my email. If you have any question, you can email me later on. And I'm going to stop here.
Fantastic. Pascal, that was great. There are already questions building up, but I'll keep them for the end. And I think let's hear from Rob. So once you get these wonderful sequences and you optimize them, and then of course Pascal will look at this and say, guys, these are not optimized. Rob, tell us, how do you interpret them?
Wonderful. Thanks ever so much for the introduction, Nikos. Can I just check? Can you see my arrow moving across the screen?
Yep.
Yeah, okay, that's going to be useful as we go along. So, yeah, so I'm a neuroradiologist based here at the University of Nottingham. I've got no conflicts of interest to declare. And you've already seen these objectives for the webinar tonight. And I'm particularly going to pick out certain parts of the objectives to talk about. Now, I'm as well as being an academic radiologist, I'm also a jobbing neuroradiologist. I report scans most days. And I'm going to come to you with a very pragmatic view on how I look at these scans, referring obviously to the consensus statements. And I would just say, I think, Pascal, your talk was fantastic there in terms of describing the sequences, beautiful images, and a very, very nice introduction to what I'm going to hopefully talk about, possibly not quite so elegantly. But in terms of our clinical use of the central vein sign, Nikos has already mentioned how the first 70 depictions of the central vein were around sort of 2007, 2008. We've been using this sign clinically on our 3T system since 2016. So we're getting close to a decade worth of experience. And obviously for the vast majority of that time, the central vein sign wasn't part of the diagnostic criteria. We were using it as a problem-solving tool. I think because we had local experience of the sign from a research perspective, and because Nikos twisted my arm, we started looking at these clinically and did find it quite useful in cases where there was either something a bit atypical about the radiology that didn't quite fit, or where there was something a bit atypical about the clinical picture that didn't quite fit. And the detection of lots of central veins in a particular case could help us to sort of fall on the side of MS or vice versa. But I think this plot is interesting. We've got here our use of the sequence, which I'll show you in a moment, in this context. And we started off a bit tentatively, and then we really sort of increased our numbers of scans. Tailed off a little bit in 2024, possibly because we were having sort of undergoing some rationalization of use of the sign. Now, the 2025 is only up until March. It's a slightly old slide. And obviously now with the criteria, including the central vein sign, we expect it will probably go back up again. But the differences in color here relate to whether the scan report actually mentioned the central veins or not. And the ones that did are in the darker gray. And you can see the vast majority of scan reports didn't mention it. And I think that's because a lot of our reports over this time frame were being outsourced, reporting companies. And I just don't think there was an awareness of the sign and what we were using it for. And I think this really comes to one of the points I want to make, is that your radiologists in your hospitals may have heard of this sign, but they may not be confident with using it or reporting it. And of course, with a lot of these scans, I would get Nikos or one of his colleagues coming down to my office and tapping on the door and asking me to look again at the scan to say whether I could or couldn't see any veins. So let's have a look at some examples. We've already seen really nice examples from Pascal's talk. We actually use the T2 star 3D EPI sequence that was developed at NIH. We've been using that on our Philips system. And as you can see here, we've got some nice examples of a central vein in a lesion where you can see the T2 hyperintensity, and we can see some more in cross-section here. And radiologists like to name radiological signs after either animals or food, and in this case we came down on food, and these have been compared to the appearances of coffee beans and donuts. And these the lesions with these veins are most commonly seen in the periventricular and deep white matter. You can occasionally see them more peripherally in the posterior fossa and so on, but they're often most easily seen in those periventricular and deep locations. Now, there is a radiological definition, which is important for us radiologists when we're looking at the scans, or neurologists if you're doing it for yourself. And the definition is here. So you need to be looking for a thin, hypointense line, or if in cross-section a dot, you need to be able to see it in two perpendicular planes. And this comes back to one of Pascal's points about having a sequence that you can reformat in the axial, sagittal, and coronal plane. And the vein itself should have a small diameter, which excludes things like developmental venous anomalies, which you sometimes see on scans, and it needs to run centrally through the lesion. So you can see that in these examples here. So let's have a look at a case where it falls outside of that criteria. So here you can see we've got some flare lesions next to the frontal horns. And we can see some prominent veins, but they're not running centrally through the vein. They're running sort of here, just coasting off of the margin of the margin of the lesion. So the veins are not central. So in this case, I wouldn't be calling these central veins. Here we can see a lesion on the sagittal reconstruction in the frontal lobe. There's possibly a little central vein within the lesion, but when you look at the diameter of the lesion, and this was the case in all three planes, it's less than 3 millimeters. So we have an exclusion criterion here of lesions needing to be 3 millimeters or greater. So I wouldn't be able to count this lesion in my assessment. You have to be careful with confluent lesions as well. So you can see here quite a large area of flare, T2 hyperintensity. when you look in that lesion, you can actually see multiple veins coursing through the lesion. So again, this wouldn't count in your assessment of the lesion. And you also have to be very careful, of course, where you have poor lesion, poor visibility, such as when you've got lots of motion artifacts. And I'll show you an example in a moment. So how do I look at these in practice? Well, I have my SWE or T2 star sequence open side by side with my flare, which is again a point that Pascal's already made. And not only does that allow you to clearly see, to compare one lesion on the two sequences, it also can help you disentangle areas which might not actually be lesional. So if you look on the T2 star here, you can see a bright area right in the middle of the scan, which you might think is a hyperintense lesion. But when you come across, you see that's actually the ventricle. And so this isn't an area of MS lesion. And here you can see nicely a central vein running through a lesion, which corresponds to the sort of chicken drumstick shaped lesion over here. You can also see some other central veins. There's a little lesion here with a dot in the middle. And again, we can see our the lesion that corresponds to. So I look in the sagittal plane, I go through the scan, I label the lesions with a little marker, and I'm trying to count 6. Once I get beyond 6, I'm not quite so careful about counting them, because 6 is the magic number that we need as part of the McDonald criteria, which we'll come back to in just a moment. And I then flip round to another plane. So here we've got the axial plane, and again, you can see multiple lesions that have got their central veins in, and try and make sure that I compare lesions in the two corresponding planes at least. So we're looking for 6 lesions. It's this select 6, or sometimes called a rule of 6 sign, and people have tried various different thresholds for numbers of lesions with central veins and looked at sensitivity, specificity, and I think the community has really sort of settled on 6 as a number that has a high specificity, a good sensitivity, and is also practically workable in practice. There are, in the early days, we were looking at proportions of lesions, which is fine, but you have to, if you're going to look at a proportion of lesions, you have to count every lesion to give you the denominator, and that can be very, very time consuming in cases with lots of lesions, like the case here. The one situation where the rule of 6 can struggle is where you have a very low number of T2 hyperintense lesions. So if you've got less than 10, for example, or let's say you've got 3 or 4 lesions, then it can be very difficult to you're not going to be able to count 6. So if you've got a small number of lesions, in that situation, we do look for proportion. And I think if you've got less than 10 lesions overall, you're looking at having 50% or more that have central veins in them to call it a positive scan. And I see my job really to count those lesions, find 6, and then feed that information into my report so that it goes back to people like Nikos, and he can use it in the algorithm to decide whether it's going to contribute to the diagnosis of MS or not. So I'm just going to show you a little video of a case here. This is a typical patient scan, and hopefully you can appreciate it's not a brilliant quality scan. This is a scan with movement on it. And of course, in clinical practice, we do get scans like this. If you look in the journal articles, and if you come to talks like this, people will often show you their best cases. But in reality, we find scans that have all sorts of artifacts, and movement is quite a common one in patients who struggle to lie still. So I'm just going to play it again, and if I can time it right, I'm going to try and pause it. And I'm not sure if you can see it. There's possibly a little lesion in there that has a central vein in it. See if I can find another one. Yeah, okay, so there's a lesion here. Again, you can just about see a central vein in it. So with these motion degraded ones, I am very, very cautious. Occasionally, if you're lucky, you can still see enough veins and you can count them and you can get to 6. But in general, if I'm looking at a scan like this, I am very, very tentative in my report. If I see a couple of veins, like, sort of 3 or 4, I will give the number, because I think that suggests that, on a good quality scan, you might be able to pick up more than 6, but you can't use it in diagnostic criteria if you haven't seen 6. And I think in these cases, often you may need to go on and repeat the scan if it's going to be critical to making that diagnosis. So it can basically, scans like this with a bit of motion on them can give you a clue that veins are present, but you do need to be very, very cautious and not overcall. Okay, I'm going to show you another case now. Again, I'll let it play through. This is a much better quality one, and if you were really sort of eagle-eyed, you might have seen a few lesions with veins in them, and I'll just sort of try and pause it again. Yeah, okay. My reaction time was good, so we can nicely see a few lesions with central veins in it here. But I'm also going to just let it play on and see if I can pick up another feature. Now, so the other feature I wanted to point out is up here, we can see a lesion, and hopefully you can start to pick up there is a paramagnetic rim on this lesion. So let's look at that lesion in 3 different planes. Here we can see nicely that paramagnetic rim just on the T2 star EPI sequence, and we can see it in all 3 planes. So this is a good example of a paramagnetic rim. My experience on these is that if you start looking for them, you'll find them more often than you will think. I'm sure many of you know the famous experiment where they showed radiologists chest CTs with little gorillas hidden, superimposed on the image, and they asked the radiologists to look for lung nodules, and a lot of them missed the gorilla. It's a sort of very famous visual perception exercise. And I think it's the same with these things. When you're looking at the SWE and concentrating really hard on finding the central veins, it can be easy to overlook the paramagnetic rim lesions, but when you start looking for them, you will start to find them. And here's another nice example where we've got these frontal lesions by the frontal horns with rims, and here in a sagittal plane you can see these very clear sort of rims around a number of these lesions. Okay, so as Pascal's already said, it's worth looking at the filtered phase if you can find it on your scanner, and you'll send it to your PACS system because it does have higher sensitivity. But the criteria for looking for rims are that you need to have at least 2/3 of the total rim that shows the hypointensity for it to qualify. And that obviously needs to coincide with the margin of your T2 hyperintense lesion. So it is sitting on the rim. And you need to have it visible on 2 consecutive slices if you're inquiring if you've only got a 2D acquisition, or 2 orthogonal planes like we can see in this case if you've got a 3D acquisition. And we're not looking at contrast enhancing lesions here, so they need to be excluded because there may be other reasons why you're getting rim effects, and they're obviously active rather than the sort of chronically the sort of more chronic active lesions. Okay, so those are the paramagnetic rims. So I mean, this has been a very in a nutshell talk because time is limited, but hopefully I've given you sort of an overview of how I would look at these things and in clinical practice, picking up central veins, paramagnetic rim lesions, and importantly, the sort of information that I'll be passing back to the neurologists in my report to feed into that algorithm for being able to make the diagnosis using the new criteria. Okay, I'm going to stop talking there.
That was fantastic, Pascal, and fantastic representation. And questions are coming, and one of the things that I'm notorious is needs. Can you hear us? Is always to surprise. So since we have needs there. Needs actually was, who is not part of this panel, it's part of the next panel, but needs has contributed to the rule of 6. And there is a question here, and it's saying that if 6, needs disappeared. Needs decided, no, needs is back again. So how do we come to the rule of 6? And there's a question from Graham. Graham Warner is that why you need 6 if you can only see 1? Why? Explain to us the logic.
Yeah, so thanks for roping me in to help for free. So when obviously you know this, Nikos, but for the benefit of the audience, when we first tried to make this useful sign on 3 Tesla MRI, we started out by comparing patients with MS and with lesions on their scan not due to MS, so migraine, blood pressure, cholesterol, whatever. And some of those non-MS patients had a lot of lesions, sometimes 100 or more microangiopathic or small vessel lesions. Now, if you scatter the brain with lesions, I guess you could statistically co-localize what looks like a vein with what looks like a T2 intense lesion. But what we found in our test cohort was that the non-MS patients never managed to get to 6 of those coffee bean or donut looking things. And so that's where we set the threshold originally at 6. So it's nice to be vindicated, isn't it, that the other groups have validated it. Then, the trouble with setting the bar relatively high at 6 is, as Rob said, if you have very few lesions, you're going to start to lose sensitivity, even if your specificity is good. So that's why we then made the second rule, which was if you're fewer than 6, but they're still in the majority, it's still MS.
I think, I mean, I like also that, there is enthusiasm. And of course, from the research group, there is a lot of enthusiasm, but it's nice to have Rob being sensitive and sensible, saying that, guys, this scan has moved a lot. I'm not going to give you the diagnosis because you're obsessed with your central vein. So this is the question that Antal is asking. Just again, a repetition, of so Antal Zabo, a neurologist that we know well, says so. The radiologist reports non-specific white matter lesions on the MRI. Is there a case of saying back to the radiologist, just look at the central vein, or do we need to do another sequence? So Pascal, why don't you fire do you think that, we can get sometimes something that looks like a vein in the standard T2?
No, it's difficult, and that's why we emphasize the need to add the SWI to the protocol, and this is what really the guidelines are pushing for now is the diagnostic MS protocol, the very first MRI, then you get the patient at initial presentation should include an SWI. Now, if you don't have it, looks like what Antal is pointing out, you can always maybe ask back for another MRI that will be including that scan specifically and ask for the radiologist to report on those biomarker. But again, I think the push is for now to integrate this sequence, and the trade-off in scan time is minimal. It's about a 3 to 4 minute scan, so it really should be doable at your site.
So, Rob, apart from multiple sclerosis, do you have how common it is to do a scan and then you going back again and requesting another scan just to get a specific marker? Or I was just thinking outside of multiple sclerosis. So, is it a big deal for us to come along and say, guys, you haven't given us the answer. Can you get us another sequence?
Yeah, I mean, it's not uncommon for us to recall people normally for incidental findings that were spotted, and we need to do another, post-contrast scan or more dedicated sequences, spot something in the pituitary, and you had to bring them back for a dedicated scan. So, certainly it's not uncommon in our practice to do that. But I think the opportunity we have with these cases is that often, unless it's completely unexpected sort of radiological isolated syndrome situation, often there is a suspicion by whoever's referred them that there may, MS is a possibility based on the presentation. And in those cases, the opportunity then is to do, as Pascal said, is to actually get the scan in, with the right sequence first time. And that's something that we're now switching to, as you know, Nikos here, trying to be much more pushy with getting the SWI or a T2 star sequence into those patients, not where you've got a strong suspicion that it's MS, but where you've got a suspicion that it could be MS, because if we can get that in early, we may be able to cut out repeat scans, diagnostic delay, and so on.
Probably an optic neuritis that we're scanning with optic neuritis. It has to be automatic, exactly as you are scanning the optic nerve with your sequence, then it has to be together, you have to do the right susceptibility weighting imaging, isn't it? Pascal, question for you from Floriana. Floriana is one of our favorite neurologists in London, and she's asking, I have access to 1.5 Tesla. You have impressed us with your optimized SWI. Can I get an optimized SWI at 1.5 Tesla?
So the good news is, yes, you can, Floriana. It's possible to, again, change the flip angle and tune it so that you can see the lesion and the central vein. I believe at 1.5T, based on our simulations, we obtain a flip angle around 8 degrees. So I would recommend you just try it out, run a couple of scans maybe, just to make sure that you see the lesion and vein properly. But it's the same physics. We just don't have a 1.5T here where we run routinely, everything is 3T, but the answer is definitely yes, it's feasible.
That's fantastic. I can give a question to Linda. How does the old McDonald criteria differ from the new, and how does this change our practice regarding if I get correct reliance on MRI or over lumbar puncture. I think lumbar puncture has served us wonderful over the last 100 years. But when we ask people, do you prefer to have a lumbar puncture or do you prefer to have another MRI? The vast majority prefer to have another MRI. So there will be cases, and I have next to me one of the neurologists trust that has found the case. The person with multiple sclerosis with two spinal cord lesions, and they probably having two relapses. They have not developed yet, where the lumbar puncture might be useful. But for the other 60 cases, the diagnosis was clear purely on either having the four locations or the central vein sign. So I think it has made a huge difference, at least in our practice, reducing the number of lumbar punctures that we do. Antal is asking, so what about other diseases? Do we see central vein in other diseases? What about antiphospholipid syndrome? Who would like to answer this? Rob? Or needs? Why not?
I've unmuted first. So I think Pascal and Rob can correct this when I go off piste, but one of the advantages of this sign is many of the confounding lesions will tend to occur in end arteriolar territory. So, small vessel ischemia, antiphospholipid, vasculitic type changes. You're going to end up with a small non-specific microangiopathic lesion in the region where a tiny artery is blocked and failed to supply that piece of brain. Whereas this is relatively unique in the lesions forming around the paramagnetic veins with the deoxyhemoglobin in them. So we've been lucky in a way that the physics fits this relatively unique pathophysiological quirk, I would say.
Yeah, I would second that. And there's actually some data. Can't remember the paper, but it's been studied and demonstrated that the proportion of CVS positive lesion in these mimics is very low. And so again, the CVS has a very highly discriminatory power here to differentiate MS from these mimics. So I will second what Nish said. It's actually useful.
Yeah, and I'll sort of third what he says as well. If you actually look at the published specificities of the sign, they are very high. It's not 100%, so it's not that this is totally specific for MS, but it is very high. A lot of the studies are up in the 80s, 90s, sometimes sort of way up in the high 90s for some of the studies. Depends a little bit, of course, on the mix of cases that go into a particular study. But I think that's looking at the central vein sign in isolation. But then when you also take into account, other features of the presentation, other features of the scan, and so on, if you apply it in the right cohort, and if you're doing your other test to exclude other conditions as you normally would, then I think it becomes very, very it's diagnostically very powerful.
There are lots of questions coming from other favorite neurologists of mine, both Katie and Anna. They ask, what about the MOG and NMO? Can we distinguish? Can we use the central vein sign? What's their value? Who would like to answer that?
I can jump on this one. So actually there's data from the UK. It's coming from Olga Ciccarelli's group. I will point the audience to the Neurology paper that they published in 2023, where they actually demonstrate the ability to discriminate MS from MOGAD and aquaporin-4 positive. But back to Rob's point, I just want to say the central vein is not absolutely entirely absent in those mimics, right? You can still have some hits, but again, the proportion of total lesion is very much different, with MS around 80 to 90%, whereas MOGAD is around 30%. So don't expect to see total absence of central vein sign in those mimics, but overall the proportion should be much different, and the likelihood of getting a SELEC6 or 6 lesion is lower, and then help you then differentiate those two conditions.
Jackie, one of our favorite MS nurses in Cardiff was saying, does it matter how the disease progress, whether you have central vein signs, and how will this inform our clinical practice? And the answer is that these are, in the context of this webinar again, this is very important in diagnosing multiple sclerosis. in making sure that we are not treating people that do not have multiple sclerosis. And every so often, of course, we find in our clinics people that we had our doubts. And this is one of the ways that Rob has mentioned. We scan them, we don't find the central vein signs. They said, oh, we have been making a terrible misdiagnosis for a number of years. So once somebody does have multiple sclerosis, it does not really make a long-term difference in the way we treat. There is a lot of discussion about the paramagnetic rim lesions because there is an association of the lesions, the people that they have more than four PRLs having a more aggressive disease, and there is a bit of debate in the community now. Do we need to treat them differently? Which medicines might make a difference? I think it's a big it's a big discussion, but we haven't got a straightforward answer. Peter is asking, because I know that there are lots of questions, but we need to go through most of them. Peter is asking, so what about how many sequences are we going to use? Probably we should ask Pascal. Should we be doing T1 and diffusion weighted images and flare in all of them? Do we have any guidance on this, Pascal?
So I'm actually going to dodge this one and pass it over to our neuroradiologist on the call. So Rob, please be my guest. Take this one.
Yeah, so we will end up using a number of sequences, and I hear our core protocol now is an axial T2, a 3D T1 volume, a SWE, a 3D flare, and DWI. So that it's 5 sequences, and and that's for a non-contrast scan, and that is a core, but that's not too dissimilar from what we would do as a standard brain MRI anyway. For just a general sort of non-specific neurological presentation, you're pretty close to that anyway. MRI always has a handful of sequences in it, so I think it's not, in my opinion, too burdensome. The problem, of course, for those of you who are in the UK will know that the NHS is pretty overrun. We're desperately short of scanning capacity overall, and every department is under pressure. So as soon as you talk about adding even on a couple more minutes per patient, you will get managers kind of pushing back. But I think for all the reasons we've talked about here, the fact it can get you to a quicker diagnosis, it can avoid recalls for repeat scans, can avoid lumbar punctures. You've got to just make those arguments that it is worth doing it at the outset.
Fantastic. So I think I might surprise everybody. I might surprise the team at the MS Academy that this webinar might finish on time. Having two Mediterranean people here, Pascal and myself but Pascal, give us one sentence if you want to say that. What is your wisdom in one sentence? So.
Well, my call is to please include the SWI in your diagnostic protocol. Rob's argument about the pressure on scan time is well taken, but the technology is there. Scanners are getting faster, sequences are getting shorter. So please include that, because for the neurologists like you, Nicholas, this is extremely useful to accelerate the diagnosis of a MS patient, treat them earlier, and make sure they do have MS.
Fantastic. And Rob, one sentence or
well,
one paragraph.
Assuming most people here are probably from a neurology background rather than radiology, my one sentence would be: talk to your radiologist about this, explain why it's important, and try and bring them along with it. Because, say a lot of them are lacking a bit of confidence in interpreting the signs, but if you show them it's not that difficult, and hopefully they'll jump on board.
I think closing this session and giving the panel chairmanship to Needs, I would say that this is a great contribution of the MS Academy. So this webinar will remain for the MS Academy website, so you can always go back and listen to it and send the neuroradiologist or the radiologist or your clinician that they might have some views. So feel free. Some of this material, they will be on this. I mean, there are a number of online sources. Pascal has created one. We have created one on www.centralvein.com. So lots of this information will be there. So we'll try to put them all together. And thank you for listening. Let's hope that we'll have fewer lumbar punctures and more confident diagnosis of multiple sclerosis based on MRI. Thank you all.